Oh, bloody hell. Now I'm a little stuck. We initially decided I would just go ahead and... हमने स्टार्ट ही नोबोलॉजी से खैर you have a मैंने तो नोबोलॉजी करना था बट मुस्तफ़ा ने जब रात को मुझे कहा कि मैं स्काइप पे होऊंगा तो मैंने कहा ओके देन you might as well do it. He probably would feel better that he was part of our course. So I just said okay. So I don't want to go straight to the station for EUS. वो दोनों उसकी है ना स्टेशन ऑफ ईयर्स पहले कर लेंगे दैट बट दैट डजंट ऑर्डर थोड़ा सा गड़बड़ हो जाता है दैट्स आई एम सॉरी डियर बट okay what we can do is in the meantime there's some things that I will start with without basically slides, and that is what are the movements in EUS, what is the difference between what we all doing and what I felt when I started first doing. I mean, there are two major things that you see. One, from red or the real picture you've gone to black, gray, and suddenly someone like me who had no idea about ultrasound, I don't know about Riyas, because of Bhavi, he probably had some idea. Grey का काफ़ी था, मुझे तो बिल्कुल नहीं था. तो मेरा सबसे बड़ा जो fear था was that कि यार, I mean, what am I seeing? Because I was used to looking at lumens, you know, or fluoro. So the first thing was that ये तो बिल्कुल नहीं हो सकता यार. The other thing that put me off was the fact that some of the guys that you see do take ages to do the case, and you just wonder because all you see is gray and black, and they are trying to find something in that gray and black, and then they tell you, okay, yeah, look, this is it. And sitting, because you haven't seen it, you can't appreciate it that much. Dusra, once you've got that picture, because that's easy. Once you've seen a few, you can pick up, this is aorta, this is pancreas, these are the vessels, kidney, liver, etc. How do you get that? And you know, what is the difference between, let's say, gastroscopy or colonoscopy, which is what we do with the scopes, or ERCP? And the one thing that I learned was that the movements have to be very, very slow. So you literally bring them down to, you know, fractions of what we normally do, because a little bit extra movement will completely change everything. Okay? The most important movement is talking, okay, and knowing where you are. Once you know where you are and you know what you want, we'll discuss that in station-based. I don't do station-based. I was taught, I saw everybody do it. But stations practically for me are stomach, esophagus, stomach, and D1, D2. These are the 4 places that you go. And what we need to understand is, when you're in stomach, what do you see? If you've got a mass in the tail of the pancreas, body of the pancreas, your focus will be stomach, because that's where you'll be able to see. Your hair, stomach is here. ठीक है ना, तो pancreas आपको stomach से ही मिलेगा, body and tail. Head of the pancreas, you'll have to go to the duodenum. You can see a bit of it, a mass if it's big, even from there, but by and large you go to the D1. And uncinate, obviously you go to D2. When I saw EUS, and Khalid is an expert, I certainly am not, there are 6 stations that are mentioned. And trying to find a normal ampulla is the most difficult thing, I feel. If the ampulla is abnormal, you'll see it, but if it's normal, then you can just see a little bit, but then why do you have to see it? So you have to try and make things simple for your own self. If you have a mass in the head of the pancreas, and your whole aim is just to do an FNA, then you can finish that whole procedure in literally a few minutes because you go straight to the head of the pancreas, you look at the mass, you take the FNA, you're out. Staging, vascular staging of pancreatic masses is obviously better done by radiologists now than EUS. But when you're doing it, you can look at it, and we will obviously show you all that, and we'll specify and tell you how do you get what. But the most important thing is to understand where you have to be to see what. Thoda sa ek concept about what the scope is doing, where it is facing, and what you're seeing. And once you get that, then it starts making sense, a little bit more sense. But movement, jo torque ka hai, I mean, for those who do a lot of cases, your scope has to be straight. We'll all demonstrate, because the movement, wo jo aap keh rahe the, somebody here said uncinate ka. Aapne bola, doctor. When you go to D2, it's literally keeping your scope straight and rotating, and literally you can see the entire spectrum of the organs that you want to see by that. Advance and pullback is very, very, very short, in small spaces. You all have linear, I assume. Radial hai? That's standard. Radial is out of order in most units except Ghaya Saab's. Ghaya Saab, you have your radial working. Our radial has been out of order, and the amount of money they asked to repair it, I should forget it. We might as well get another linear. Most people now use linear, and I'm sure during the course we'll touch what we use a lumpus. We have a lumpus system. I think when I've seen the systems, I've found scope maneuverability, I found Fujinon the best. But the pictures I found in Pentax a little better. But overall, I still feel that Olympus is pretty good. If I have a choice, then I would go for Olympus. I don't know what's Khalid, aap?
So I have used the Fuji. I have used very little, but the Pentax I've used some, and Olympus. That's what it is in our unit. So I look at you have to gain something with Olympus and lose something with that. And same thing is with the Pentax. Pentax images are because the transducer is a little bigger and it's less curvy, so the images are bigger. And also, I think with that, images being bigger, images being more sharp, resolution being better of the EUS images. So when you look at the images, you really like it. But then you compromise on maneuverability of the scope, and especially when you have to do interventional stuff with that. So with the Olympus, I find it better, and that's what I'm used to because that's what's in our unit. So with the Olympus one, maneuverability of the scope is, and handling of the scope to me looks much better than Pentax. And especially, has anybody used the Pentax?
We are using the Pentax, but the old version.
Yeah, old version is even a little bit more difficult. If you look at the transducer, and you can see that it's like a bent is quite bigger, and so it's hard sometimes to intubate from the oropharyngeal area and then going into the duodenal bulb and through the duodenal apex. It becomes a little harder. But I think they have new scopes now. The transducer is smaller in size, maneuverability is better, and I think it also depends on the finances too, and that's a cheaper as compared to Olympus, and also depends if you need their support with regard to repair and who is able to better provide that. So I think you can, bottom line is you can work with any of the scopes as long as you know what are the features of the scopes.
मेरा पाकिस्तान के पर्सपेक्टिव में 3 चीज़ें याद रखें, ठीक है। एक तो है कि मैन्यूवरेबिलिटी। आई एग्री विद व्हाट साद हैज सेड दैट फ्यूजी स्कोप इज जस्ट एज easily maneuverable as an ERCP scope. उसमें ERCP scope और जो EOS scope है उसमें इतना स्मूथ हैंडलिंग है, एक जैसी कोई डिफरेंस नहीं है। बट द इम्पॉर्टेंट थिंग दैट आई वांट टू कन्वे इज कि ये याद रखिए बैकअप सर्विस। Go for a vendor who provides you a good backup service. In the absence of good backup service, let me tell you that EUS scope repair costs so much that at times it becomes difficult to find money to get it repaired. एक simple सी उसमें खराबी होगी तो this is going to cost you something around 5 to 10,000 US dollars, 5 to 10,000 US dollars. तो इसलिए हमेशा वो and then durability of the scope as well. फ्यूजी का मैंने देखा कि ठीक है उनकी बहुत अच्छी स्कोप है लेकिन उतनी रोबस्ट नहीं है, उतनी जो पेशेंट्स के ऊपर हम इफेक्टिवली उसको लॉन्ग टाइम के लिए काम कर सकें उतनी अच्छी नहीं है। बट देन पेंटेक्स इज गुड। आई फाउंड ओलंपस एज बेस्ट आउट ऑफ द 3 क्योंकि वो सबसे ज़्यादा स्टडी और सबसे ज़्यादा रोबस्ट मशीन है जो कि ओवर द ईयर्स आपको धोखा नहीं देती।
आई थिंक इसमें एक और बड़ा एस्पेक्ट ये कि 3 महीने के लिए गया इसको। दे कैन नॉट रिपेयर इवन ओलंपस हेयर कैन नॉट रिपेयर।
हमने जब कराई थी पेंटेक्स की देयर वाज देयर फॉर 3 इयर्स।
ओह शाबाश।
नहीं थी पेंटेक्स ने यहाँ नहीं बनाई हुई थी उसकी लैब वगैरह में, तो लेकिन से ज़्यादा
यूएस कोई भी नहीं
अब
रिपेयर करता है।
लेकिन अब उनका ये है कि अगर जाती है तो वो बार सर्वर की बात है 3 महीने या 2 महीने में आ जाती है। पहले तो ये था कि बिल्कुल गई है हम तो भूल गए उसको, फिर ये दोबारा नहीं आएगी। तो दैट वाज द रीजन। एंड अब व्यास इज वेरी राइट कि बैकअप सर्विस अगर देखा कि ऑनेस्टली स्पीकिंग जो नंबर्स भी है तो कर देते हैं आपको जैसे भी है जैसे ये बात
नहीं मैं आई थिंक ये बड़ा इंपॉर्टेंट पॉइंट है व्हेन यू आर ऑर्डरिंग एन इक्विपमेंट इवन जस्ट यूएस को छोड़ के इवन एंडोस्कोपी इक्विपमेंट आई थिंक बैकअप नहीं है तो आप लटक गए ना। वंस द स्कोप गोज एलिवेटर टूट जाता है, एलिवेटर इज गॉन। बिफोर आई रिक्वेस्ट खालिद टू स्टार्ट द टॉक आई हैव टू इंट्रोड्यूस just 2 faculty members here sitting at the back. Sajda did not introduce herself. Professor Sajda Qureshi, she is professor here in surgical ward. They keep changing the number, it's 5. We have numbers and I don't know, they keep changing the numbers. And Sajda has been a member of our team since we started. And mashallah, she does everything. Not EUS, but she organizes all our courses along with Professor Shahryar, who is the computer, along with endoscopic backup ke saath, he is the computer man of our unit. All our reporting system, everything that you see here is all homemade and all done by Shahryar. Both of them they are surgeons, but they do all advanced endoscopic procedures. They've not, for some reason, not been so much interested in EUS because they've got robot, so they're now busy doing their robotic surgeries. So without these 2 backbones of our unit, our courses would not be possible. There are a lot of other people who are obviously involved, and towards the end we will thank. What we will do is we change the order of the talk a little bit because Mustafa Araim was. I felt we'll give him this opportunity to at least connect to us from US. Kindly agreed. Khalid, we'll start with the stations. Is that what you're going to do?
Yeah, I think it's fine. It's won't make much difference.
I
So we can-
apologize for the delay and inconvenience, but this is beyond my control.
Okay. First of all, thank you, Saad Bhai, Shahryar, and Sajda. So it's always pleasure to come here, and that I really feel I'm back at home. Where did he go, Shahryar, or the computer guy? Every time he changes the password for Wi-Fi, and I need that. Every day. Every day, okay. So anyway, with that, it'll be I'll talk a little bit about the stations, and one thing, what I'll do is, after talking about the stations, what you read in the book, those are like when you start reading about it, start watching the videos, they talk about station 1 to 6, and those are the stations which are for the book. Okay, so then you have to come up with your own stations. That's what how I do. Like you make a pattern, you make a way of doing yourself, and then stick to that. Every single time you do a EUS, do all those stations. So what I say is like start with one. That way what happens is like you won't miss anything. So when I started doing EUS, every EUS has to has 5 components to that. Doesn't matter if I'm doing it for a submucosal lesion, doesn't matter I'm doing it for a pancreatic lesion, but I would do a complete EUS examination, and that's really how you learn. You have to just make a pattern of yourself. So first, at some point, I will talk about the stations, how they mention in the book, and then I'll talk about the stations the way I do it. You pick up the way, whichever way suits you, but make a habit that every time you do a EUS, you're going to start with that one point and then finish with that. That sometimes what happens is patient comes with a particular problem. Like, okay, it's a let's suppose it's a gastric lesion, it's a submucosal lesion. So if you start with the stations, then you're spending your time, maybe 10 minutes, 5 minutes, and patient becomes unstable. And the purpose the patient came for, that was never addressed. So for that, what I do is, I go to the problem first, take a look at it, take care of that, and then start my stations. Okay. But just try to do, every time you do it, do the complete EUS examination. Each EUS examination has to have a mediastinum. It has to have a complete pancreas, left adrenal, celiac, and then D2 examination. So just make that like 5, 6 components. And then you can, as you go along, you can add more components to that, whatever you want to take a look separately, and just keep adding to that. So first, this is really a one talk. I have everything included in that, the whole EUS. So I'll just probably do portions of this at a time. So the first one is when the EUS came, really, there was a lot of talk about doing how good it is for the staging purpose. That utilization is decreasing and decreasing, and that role is decreasing and decreasing because the imaging technology, especially CT scan, MRI, they're becoming much better. And now it really has a role as a complement to the other imaging with regard to the staging purpose. But where it still does better is the submucosal mass, smaller lesions in the pancreas, and also early features of chronic pancreatitis. Common bile duct stones, we have a radiologist with us, but as we know, the CT is really worthless for common bile duct stones. And MRI, pretty good, but 5% of the time, especially the very distal bile duct stones close to the ampulla, that can miss that. And EUS does really good at that. Not 100% sensitive. People, I have done that too. I know that there is a stone. Sometimes you may not see it. It's a small stone. It's really in a place that you know you have a, maybe there is, maybe there is not. But the clinical presentation is such that you note that there is obstruction, there is a stone, you do a ERCP and you find it. So, but EUS does really, really good with the bile duct stones. And obviously, nothing compares to EUS when it comes to tissue acquisition, biopsy, IR, radiology. They can do it, but they have to do, obviously, go through the skin, and we can do that internally. So nothing compares with that. And then EUS guided interventions and therapeutics. I don't think that's the scope of this course, but I will, at the end, I will mention a little bit about that. We all know that it combines endoscopic and EUS together. the ultrasound transducer that is at the tip of the scope. And again, I was mentioning earlier that whatever system you use, you have to know your equipment first and how it to operate that, how it works, how is the bending length of the transducer, what is the diameter of the scope, and so all these are very important. Once you get used to those things and you know how your scope works and how to maneuver that, then pretty much you get used to that, and every other system doesn't look that as good as what you are working with. Okay. So EUS accuracy, less than 1 millimeter resolution. CT scans are getting really, really good. I don't know what the latest cuts are, and what are those, like they can do how many, 5 millimeter, 3 millimeter cuts? 0.6, no, yeah. So getting better and better, and the EUS really is really, really good resolution. And safety as far as is concerned, it's just like endoscopy, not really much more than that. Maybe adds a little bit more risk because of FNA, and obviously when you start doing interventions, a little extra risk with that. But the rate of complication really, especially with the diagnostic EUS, should be less than 1 in 1,000. So 2 scopes. Nowadays, I think we can forget really about the radial scope, but I do talk about that just to give an idea. There are actually there is now 3rd generation, I should say. So there are 1st generation, when they were doing a EUS, everybody was doing radial. So radial was the main scope. That was in late 80s, early 90s. That's when they were doing. And it was radial scope. Everybody would do the whole examination with the radial scope. And linear was just used for FNA or therapy. So that's the 1st generation of endosonographers. They were good at radial, and linear was just being used for FNA. So then there was a 2nd generation, like me, who have access to both scopes. And then based on the indication, we would use either radial or linear. If it was a luminal cancer, luminal mass, and something like rectal cancer, esophageal, gastric, for those, or other main thing was some people still use that, some of my colleagues still do that, especially to look for the bile duct stones or just the features of chronic pancreatitis. They still use the radial. So basically diagnostic purpose. And now the latest generation in last 5-6 years, who are all the people who are getting trained in US, majority of those don't have a concept of radial. So everything pretty much is being done with the linear. And one of the reasons is like role of staging, role of EUS in staging of cancer is decreasing, and so is the use of radial. But we have access to both. For my fellows, for my trainees, I use both of those. I think the ratio would be probably 15% radial, 85% linear, but I still give them a good exposure to radial. We do so many EUSs, so they get enough of those. So the difference between those is radial is like a CT scan. It's a 360 degree imaging, and like an axial CT cuts. And if you look here, do you have a pointer here? Pointer here? Yeah, I can see. Okay, so here is the transducer. So it's like when you look at the imaging, it's perpendicular. It's like a CT scan, but the scope is really straight. So when the needle comes out of the scope right here, you still have a working channel, by the way, on radial scope. You can use a biopsy forceps. You can use other instruments through that. But what happens is, when a needle comes out or whatever comes out, that's not in the plane of the transducer. So that's why really you don't see it. It is in the plane in a sense. You see a very small white dot. You don't see the needle completely. As compared to radial, if you look at the linear, needle is coming out from the working channel and it is always right in front of the transducer. Always right in front of that. That's why you are able to see the needle in the real-time fashion. The other thing is, this is 360 view, and with the linear, it's now almost 120 degrees. And they both are really equipped with the Doppler, but with the linear Doppler, one of the major reasons is you can differentiate between a solid or a cystic lesion and the vessel. So you put that on and that helps you determine where the vessel is and you can avoid that. And for therapy, for FNA, for intervention, obviously you need a linear scope. So if you are buying a system now, you really don't need a radial. If you already have a radial, you can utilize it. But nowadays, majority of the units who buy EUS, they really don't buy a radial scope. We have a radial here, right?
We do have a radial here.
But is it functional?
Yes, it is.
Okay. And gas bhai, आपके unit में है? आपके भी नहीं है?
No, normally we don't, but we only have it for the board.
Okay. Yeah, that's what it is. Like people really are not using a radial anymore. So I still like to use that because my training, half of it was radial, other half was linear. So I did a full year of training in EUS. I think I probably did 200 to 50 radial and the same amount with the linear during that year. So I think I consider myself lucky I can function with both scopes. And this is, you can see, you might have, you have seen this picture before too. This is like a linear, and this is a radial, and this is an endobronchial ultrasound. Sometimes you need a whole unit for, you need a box for that. It's a separate one, but you can use this in the kids, and also if you really, really want to do a very close staging of esophageal cancer and the lumen is really, really small, we can use that. But in last time I used probably was many years ago, because we really don't use it for the purpose of staging anymore, much of that. And it does can provide it. You can get the needle through that. It's a special needle, but the functionality of that scope is not that great. But it is available. Okay. Other thing, few terms which you use in ultrasound is mainly related to the echogenicity. 3 words which you are going to come up with is anechoic, hypoechoic, and hyperechoic. Anechoic, there's really, it's mainly for the fluid, and which could be in the shape of vessel, ascites, cyst, bile in the gallbladder, and sometimes fluid in the bowel. They all give an image of, there's really, it's all black, and that's an anechoic. And then there is a term used, hyperechoic. I'll show you the images of that. That's basically when there's inflammation in a solid organ or in a, and cancers, they look like they look hypoechoic. And hyperechoic, if you look at their air can be hyperechoic, fat could be, stone could be. Here, what I put it is blood here and vessel here. So vessel, anechoic, blood, hyperechoic. Why did I do that? Vessel has a blood in there too, right? So when the blood is flowing, that has no echogenicity. When it is clotted, it has a echogenicity. So if you see a clot,
If you see a thrombus in a vessel, that is going to be hyperechogenic. Okay? So clotted blood looks hyperechogenic. This is a example right here. You can see here no echogenicity. There's a liver cyst there. And then you can see here, it's like a granules, white and black granules. That gives more like a hypoechogenicity there. And then this is a stone right there, which is giving a nice shadow, but the stone itself is hyperechogenic. Okay. So now principles of imaging, station approach, I mentioned a little bit about that. And when you start doing the EUS, and you're going to get lost all the time, especially when you have a scope in your hand, you're in one place, and you are like sitting there, have no idea what the structure you are looking at it. And even though you followed your stations, you followed all the principles, but you still get lost. So always there are some major stations, like it's easier to find a celiac axis area. It's easier to at least get into the duodenal bulb. So just come back, if you're lost for a few minutes, just come back to the most familiar area and then start over. And so eventually you'll get used to that. It's the really, with the colonoscope, EGD scope, we are used to doing a lot of movements with the scope itself. And if somebody does that with the ERCP scope or EUS scope, I call those purposeless dancing movements. They need to be stopped, really. You can't make too many movements. It's a very, very slow movements. And it's you have to move by millimeter. That's how you do, especially with the EUS. And the same thing is with the ERCP scope as well. You have to unlearn colonoscopy to learn EUS and ERCP. So everything, and EUS is other, as I think Dr. Saad was mentioning earlier, we are really used to red and white. We like blood, looking at the blood, white stuff. And you have to just change your gears, change your mind. You have to get used to black and white. Okay. And people sometimes they are looking at it, they have, yeah, I just see black and white, I have no idea what you are looking at. That's what usually the EUS, and you have to just be able to switch your gears. So these are the, a lot of you have probably seen these before, but this just gives you an idea how the scope moves from esophagus when you're looking at through the stomach, how that's gonna scope, where the transducer is, how it is moving through, like this, starting at the GE junction, you are moving into the stomach. And I will come to those stations later, but this is to give you an idea with the linear where the transducer is and how that is imaging and what structures it is looking at. So that was from there, from the stomach. Now, the next step is you go to the duodenal bulb, and I'll take a look at the scope position. And look at the structures, what you are looking at. Other thing is, when you're, these are like doing a shoulder movements and wrist movements, what you're doing. Here, if you look at the scope position, I will demonstrate all that in the live, and will show you a little bit more these images as well. When the scope is in the stomach and you're looking at the pancreatic body, pancreatic tail, pancreatic neck, by the way, you can do a whole exam pretty much of the whole pancreas from the stomach. You don't really have to go into the duodenal bulb. You can get all that exam done. But majority of the main thing what you are going to learn is how to take a look at the pancreatic body, neck, and tail from the stomach. If you look at it, if you pay attention, the scope, when it came down into the stomach, it was really a straight scope. Okay, so you very straight. But when you go into the duodenal bulb, I don't think this really justifies the whole how the scope is. Scope usually is not here. Scope is like coming here and resting on the greater curvature of the stomach. So the transducer position completely changes. So you have to keep that in mind. Different areas of the stomach or intestine and different places, the transducer position is totally different. Sometimes it's looking from the top, other time it's looking from the bottom. So it keeps changing, and based on that, you have to be able to recognize what position you are in, and what structures that you are looking at, and what is the position of the scope itself. So this is station 1 and 2, what you read about station. Those are not for me, those are not. But I'm going to go through the book stations first, and then I'm going to go through the stations the way I do it. So here you're looking at, now look at it. First you were looking from the top down, now you're looking from the bottom up. So you have to keep changing your orientation of anatomy and get used to that. So it's that's the thing is different from endoscopic view. You know, you do a AEG, you know exactly where you are. But this with the EUS, every time you're looking at one structure from different angles, and it's going to be in a different position in the from the other angle. Okay. So these are the stations what you read in the book. Station 1, 2, 3, which is pancreas, head, and uncinate. Station 4, which is basically stomach, looking at the neck, body, and tail. And the station 5 and 6, they are the mediastinum. To give you an example here, that's the station 1, 2, 3, and how the structures look on this. Where the transducer, how the transducer is looking at those structures, and what structures you are seeing here in station 1, and then station 2, station 3. Basically, all this is really in the duodenal bulb, second part of the duodenum. You go a little bit into the third part of the duodenum, which they call the station 1. When you are in duodenum D2, I think majority of the people usually have that problem with the D2. So when you are in D2, there are two really ways to take a look at the structures. One is you take a look at the ampulla and put the transducer right on top of that. Okay? When you put the transducer right on top of that, you are never on it. You are always distal, because the camera is 1 centimeter behind the transducer itself. So you have to pull the scope back after putting that on that before you do your right and left movements. So pull the scope back a little bit. You look for the ampulla. Mainly you're looking for the bile duct and the pancreatic duct. And when you find the bile duct, if you go left torque from there, you find the aorta. Aorta, I usually call is, what I call is like find the aorta in the D2. When you find the aorta, it becomes easier. When you are in, from the GE junction, when you come down, the way the aorta is, it's kind of a landing, like a plane is landing, it's coming down. Okay. When you are in D2, when you are in D2, it's kind of going up. So from GE junction this way, from D2, it's going to be this way. So it's just because of the position of the transducer. So in D2, when your aorta is lying in this position, it shouldn't be flat, it shouldn't be straight, it should be kind of at 45 angle. So that's the center. Once you find that, things become easier from there. That's the center of 5 structures. There are 2 on the right, 2 on the left. 2 on the right, what I'm looking for is the bile duct and the pancreatic duct. Obviously, you find a uncinate process there. So I'm not considering that as a part of those 5 structures. On the left, it's going to be IVC and the right kidney. No matter what you do, every human is the same way. Always you're going to find those 5 structures. So bring the aorta in the center, 2 on the right, 2 on the left. Okay, so that's how you make the D2 easier. So first I described about finding the papilla and then putting the transducer. That's one way. Second way is you just go into the D2. That's the area, only area where you can move a little bit extra to find your aorta, okay? It's not millimeter movement. Here you have to move a little extra, the scope, torque right or left. But find the aorta, and that's how you find the other structures. So that's, these are those stations. All these will be, EUS is about the repetition. Nothing has changed. Body hasn't changed, and EUS hasn't changed much. It just, the functionality of the scopes is getting better, but nothing has changed. It's the same ultrasound images, the same human body, nothing else has changed really. So that's, it's going to be a repetition, repetition, repetition. And I probably have done 8,000, 9,000 EUSs. Still, at times you get lost. And the people who started EUS, I see them lost all the time too. And those who have done 20,000 plus, some of my colleagues, and I see them lost all the time. And then at times there are three of us looking at one thing and trying to figure out what that is. And so it's nothing, it has to be repetition and repetition and repetition. You can't do without that. Yeah, I guess in that sense. But that is going to happen 1 to 2% of the time. Okay. Okay. So just to reassure you, 98% of the time you'll be fine. Okay. Yeah, because you have to, whenever you're landing on, when you're putting your scope onto that ampulla, you're putting the camera there, right? The lens right on it. Transducer is 1 centimeter distal. But scope, with endoscopic view is of the ampulla, but the transducer, EUS, ultrasound transducer scope view is not of the ampulla because it's 1 centimeter distal to that. So you have to pull it back to really take a look at the ampulla. Okay? So this is that station 4, which is really from the stomach G junction to the stomach, and you can take a look at those structures. What you find, first you look for the celiac axis. From there, you follow the celiac axis, and I think not the surgeons. Who's going to tell me about the branches of celiac axis? I hope the surgeons know. Okay. So celiac artery divides into how many branches? 3. Which are? Okay. So usually what happens is the left gastric which comes off as a branch first. And other thing, remember, everything on the EUS on the right of the screen is the left of the patient. Left on the screen is the right of the patient. So even though it's a left gastric artery, it's going to come to the right. And then it divides into common hepatic and splenic, but a lot of times you're going to see what I call a trifurcation. So they all come out at the same time. Other trick question, I think probably a lot of you heard before, what is the first aortic, what is the first branch from aorta under the diaphragm? Phrenic artery. So majority of then you don't see that. The only thing as soon as you're below the diaphragm, you see the celiac, but that's just for fun. Okay. Yeah, so here you can see that actually in this picture. आपको सोने के लिए नहीं कहा, इधर वाले बंद करो, वो पीछे बंद हो कर रहे हैं ताकि सो जाए. Other thing, yeah, here you can see that there's a celiac, there is a SMA. SMA almost always comes right in front of the aorta. Surgeons can correct me if I'm wrong, but the celiac doesn't do that. Sometimes the celiac is coming off the right or left of the aorta. So when you go down below the GE junction, you find this nice branch coming off the aorta. Don't assume that's a celiac. Okay. So a lot of times you're going to see it's a SMA. You have to pull it back. You follow SMA and you're like, oh my God, I followed it for like 5 centimeters. It's still not dividing into anything. You realize that, okay, you are on the wrong artery. So you have to just pull back a little bit. And for celiac, you have to go a little bit right or left. Other thing is, same thing is, when you follow that, you get to the splenic artery. You see a splenic vein as well. When I come to that, it's again, I'm going to keep repeating a few things. So sometimes you see the splenic artery on the top, splenic vein at the bottom, pancreas is on the left side of those, and you see that there are 3 vessels, like instead of 2. So splenic artery has a zigzag course sometimes, and you may be looking at the splenic artery from 2 different planes, but it's really that one vessel. So that's another thing which you, when you are looking at the pancreatic body, always bring the splenic artery and vein to the right of the screen. So that means you're in the right place. Sometimes people are looking at the retroperitoneal fat, and my fellows who do probably 5 to 7 EUSs every day, and every 3rd day they are looking at the retroperitoneal fat and looking like that pancreas looks really nice, but that is not the pancreas. Okay, so you have to have those main like landmarks in the right place to take a look at the right organ. Mediastinum, you won't be much doing a EUS of the mediastinum, but main thing you are looking at is subcarina, AP window. I have done an FNA of the thyroids too through this, lung masses, but usually I don't think you're going to do majority of those. I think it would be best to show you that in a live case, and I'll show everything from the thyroid, AP window, trachea, and subcarina, all that stuff. So when we can get to that, then we'll talk about that. FNA biopsy. Yeah. And for us, it's majority of the time it's a lung cancer and the lymphoma. That's where we end up doing that. Before I go to this video, I want to go back and take a look at the stations, the way I do those stations. For me, I start at GE junction, right? Okay. So for me, I don't know who named these stations. Actually, I don't know what state of mind they were in at that time. They started from bottom up, which is fine. Then it looks like nice numbering, but that's really not how you do the EUS. So in my opinion, the station numbers should be the way you started. Okay. So for me, these are the stations how I do it: GE junction and stomach. Stomach itself, GE junction, that's station number 1. So everything you do from stomach is station 1. Okay. So what you see from that station 1, you see the celiac axis, you see a pancreatic neck, body, tail, as I mentioned. You can take a look at the head too, majority of the times. And then you take a look at the left lobe of the liver. Gallbladder is going to be towards the lesser curvature of the stomach. You take a look at the left kidney, left adrenal, spleen, splenic artery, vein, portal vein confluence, spiromesenteric vein. Other things which I did not include is you can see the renal vein itself too. And you can see literally the whole bile duct. You see the common hepatic duct. Actually, the best place to evaluate the common bile duct is really especially the diameter of the common bile duct is not the duodenal bulb or second part of the duodenum. You always compress the bile duct from there. So it's always going to give you a smaller diameter than what was on MRCP. So best place really to take a look at the diameter, actual diameter of the bile duct is the stomach, if you can find it from there. So actually my fellow, previous fellow, he wants to do that study, and I'm still, for last 2 years, I'm waiting on protocol for him to start. So, but the best, we don't give a, on EUS, I personally don't think we give the right diameter of the bile duct in the report. I think we're compressing that. Okay.
How often are you able to find CBD from the stomach if it's not that?
We'll see, but majority of the time. And but I'll show how to. Skinny people, all the time, and if they are they have a little more fat pad, it becomes a little bit difficult. But I'll show you how to find it, and you should be able to find it 80 to 90% of the time, and even a portion of the head, if not a full head of the pancreas. So I'll show you that. Yeah. More and more you do the EUS, more and more you start looking at these things, the things which you didn't pay attention to before, they become more and more apparent, and then you make the connections what those are, and you realize you're seeing a lot of stuff which you were ignoring in the beginning, and it's good to ignore. Please ignore everything you see beside the pancreas or beside the structure you are looking at it. Don't keep asking what is that branch, small branch coming from that certain artery, because I really have no idea what that is at times. Okay, eventually may be able to make a connection, but if I'm looking at the pancreas and you see some small vessel capillary coming there and asking me what that is, I have no idea. Okay. So other.
Can I just what you just said, is it really worth knowing?
No, not really. Yeah, and the people get lost into those small details looking for the zebras, and they can't see the elephants there.
This is something that actually makes this very relatively simple procedure into a very complex procedure, because you start digging out or looking for things, especially when you see those real experts who just spend like hours on vascular anatomy, of which we have nothing to do with.
Usually I don't listen to those experts. Majority of the time, they really have no idea what I shouldn't say that blunt, but majority of the time, when you ask them a simple question, they may not be able to answer you that. They can tell you what branches those are because they have memorized many of those, and but they cannot demonstrate that.
It's easy for me because I can't understand.
Okay, good.
फिर जब एनकेसमेंट आ रही होती है किसी ट्यूमर की, उस केस में आप रिपोर्ट में लिखते हैं ये वेसल्स ये एनकेस्ड है ट्यूमर से या ये
You mean the vascular involvement? Yes. What I do is, actually, that's a part of the talk. So let me come back to that, where I mentioned that. So I'll show the image of that. I do mention about that, but let me come back to that. Gee.
I want to make a comment. Referring back to the comment that is being made by Saad, I think the state where I and Saad, or the way we have been trained, I think for us it is like looking at the CD, looking at the MR, and going right after the lesion, and then looking at the things which are pertinent or relevant to that particular thing. But for the young people, for the
Absolutely, and absolutely agree. And if you have access to actual radiology images, CT scan or MRI, you should try to take a look at those yourself with the radiologist, if possible, and then do the EUS after that. For us, majority of the time, that's not available. Patients coming 2-3 hours away from somewhere, they're bringing just the report, no access to the images. Different healthcare system who don't have access to their radiological images, and I really don't even look at those. I don't. Only time I want the images is when I'm looking at the mediastinum, especially the lung cancer, or they're seeing something, they're telling me, oh, it's a few centimeters away from the esophagus, but we see it, you may be able to access via esophagus. So in those cases, I try to take a look at the image to give me an idea where I need to look for that, because air in the lungs sometimes makes it difficult. So then what I do is I just try to compress the esophageal wall as much as I could with the transducer to get to that area. So those are the those type of cases I try to see if I can find the images. Next thing, how many do ERCP? Pretty much everybody. Endoscope, simple way, I've said that many times, is you're looking straight. You're looking straight, you're walking straight. ERCP scope, you're looking at the ceiling, walking straight. That's how the ERCP scope is. EUS is right in the middle of that. It's like at a 45 angle. So you're not looking at the ceiling, you're not looking straight, you're looking where the ceiling and the wall meets. Simple. So that's just keep that in mind, especially when you are going through the stricture, you are going through the pylorus, you are going through the duodenal apex. These are the things very important. You need to see, at times the stricture is so tight, the only way you can pass through that is like not by looking at it, when your scope is just aligned straight with that. And that happens with the ERCP sometimes, especially when there is a pancreatic tumor invading the duodenal wall, stricture. Many times I just, in those cases, when if you are under fluoro, you can see the ear in the lumen. And so what I do is, I don't take a look endoscopically. I do the under fluoro. I try to pass the scope, keep it straight, aligned with the stricture, just gently advance it, no problem. That happens, so keep that in mind if that happens. So here, if it was a ERCP scope, we say that you have to let the sun set completely, and then you can get into the pylorus. Here, just still take a look at the, sometimes take a look a little bit of the sun, have that in view for EUS scope to pass through. For me, station number 2 is the duodenal bulb. Okay, so that's from stomach, that's where I go to. And the things which you are going to take a look at that is left lobe of the liver, a portion of the right lobe of the liver, especially segment 5. You can take sometimes you see gallbladder from there, common hepatic and common bile duct, ampulla you see from there, and obviously pancreatic head and neck, and the portal vein, confluence, also for the minor papilla, especially in cases of pancreas divisum. You can see uncinate process, you can see a lot of other structures, and I will try to point those during the live cases. When you are in the, once you go into the duodenal bulb, and your scope is resting on a greater curvature in ERCP, what we call a long position of the scope. Okay, so when that is in that position, go endoscopically through the pylorus, inflate a little bit. I know that we all know ultrasound does not like the air, but that's the time, inflate a little bit, okay? See where the duodenal apex is. take the scope right to the duodenal apex, transducer, take it right there. Your goal is to put the transducer in left upper corner of the duodenal apex. Okay. When you do that, I use a balloon on linear too, but you don't have to. If you are using a radial, obviously you need a balloon. On linear, you don't have balloon, no problem. If you have, just put a little bit water sometimes in there, but many times you don't have to do that. Once you put that transducer in left upper corner, big wheel towards you a little bit, suction, you will always find one of the three structures, either the pancreas or the bile duct or the portal vein. So once you find one of those structures, forget about endoscopic view, okay? Then you should know what you need to do from there to get to the rest of the structures, okay? So different if you find a portal vein, you usually have to gently advance the scope, like just put a little bit pressure on the scope so it can get into a more apposition to the wall, and then you rotate to the left, that will get you the bile duct. Once you find any structure you want to examine, your goal is to keep that structure between 4 and 7 o'clock position. And then just follow that, keep that in that position, rotate your scope. Your movements should be in a way that structure stays between 4 and 7 o'clock position. It doesn't move from there. And you will see when you make that habit, you can see a lot of stuff, and it becomes very simple following those structures. And once you are done with that structure, you come back to where you started, the same position, and then you go to the other structure and then follow the same principle. All this would become you'll be able to understand more during the live cases. So station 3, station 4, for me it's D3 and D2. These are the structures. You can see the when I mentioned about D2, when you're at the aorta, IVC, right kidney, sometimes you can find the right adrenal as well. Obviously, you see the IVC. The best position to take a look at the SMA and SMV together is D2. Remember that when you're at the G junction, aorta is coming this way and the vessels are going that way. When you are in D2, aorta is coming this way and vessels are going this way. So that's how you keep in mind. That's how you're going to find those, especially mesenteric vessels. It becomes opposite just because the position of the transducer itself. This one I already mentioned, so I'm going to go back to the other one. Okay. So this is a examination of the pancreas. This video, I think it's complete examination really without much editing, maybe a minute of editing. It's a 3.5 minutes actual exam of the whole pancreas and pretty much whole EUS. Here, if you look here, you can see, actually hold on. Let me make it bigger. Okay. So we are in the stomach. What I say is, as soon as you get into the stomach, I'm going to keep repeating that many times during the course. As soon as you get below the GE junction, your goal is endoscopically go towards the opposite wall of the stomach. Your scope is going to be what I call a neutral positions. Scope is sitting on your palm. Wheels are facing up. Scope is really, really straight. If you're really tall, you can get close to the patient. If short, step away from the patient. So scope can stay straight, because every movement you make with your wrist or your shoulder, if it doesn't transfer from the area of the movement all the way to the transducer, you didn't do any good. So it should be one-to-one movement, which needs to be transferred from here all the way to the end of the scope for it to be effective. And that happens only when the scope is bent. If you are standing really close and your scope is bent, you may have to do a lot of movement to just make a small movement at the transducer. So just keep that in the basic principles. So here you get into the stomach, you go to the opposite wall of the stomach, your scope is in a neutral position. Use the suction to deflate the stomach, big wheel towards you. That would get you to the left lobe of the liver, right there, okay? Once you are at the left lobe of the liver, pull the scope back a little bit. Scope right now is at 180-degree position. It's just sitting right, like on the floor, you can consider that. From there, scope is gonna come to 90 degree. When you do that, that is gonna take you straight to that aorta, okay? So here, I'm at the left lobe of the liver. You actually can do all the, you can follow the IVC all the way to the right atrium if you're really interested in that. You can take a look at the hepatic veins. You can look for any clots, blood carry, whatever you need to. So, but let's not get distracted and let's get to that position of 90 degree. You see that? When I came to aorta, right there. And here, this other thing about the celiac is sometimes it looks a little crooked because it could be coming from the side and it looks like there may be a stenosis at the origin, but it really is not the stenosis, it really the way it's coming off the aorta. And when you see that, you know that you are the celiac. SMA almost always have a very straight course. It's very straightforward. Usually, I think bad example, it's like men, straightforward, okay? And I don't want to go beyond that. Okay, so here, you can see that right there. I wasn't wrong. Okay, anyway. So here, you can see that celiac right there, and hopefully at that left gastric came. Other thing is people get confused with this thing is like when you find the celiac, that I have to follow the celiac. You don't like follow the celiac, it's never going to stay celiac. It's going to turn into branches. So your goal eventually is to find the splenic artery. So you just keep following until it keeps dividing and until you find the splenic artery. After you find the splenic artery, the goal is to bring that to the right side of the screen. Okay? So here you can see that it's on the right side of the screen right there. Pancreas is right here. Okay. This is the left kidney right there. This nice looking pancreas right there. To go to the tail of the pancreas, you have to pull the scope back and keep rotating to the right. Here, tail is always tucked in between the left kidney and the spleen. And sometimes they CT scan, MRI says there is a lesion in the tail of the pancreas and you're struggling to find that. The reason is you're not following the tail which falls off, like it falls away from the stomach, but you keep looking at close to the stomach. So you have to follow the pancreas and you have to kind of push the transducer to go deep a little bit to have a deeper image to get to that lesion in the tail of the pancreas. So here left kidney, now from there I'm going to the opposite side, left torque, and rotating the scope to the left. You can see right here. So here, this is a splenic vein, this is a SMV right here, and you can see that it's making a confluence right there. And right there, that's a pancreatic duct. Ooh, sorry. May, 2 minutes. And here, I'm still in the stomach, by the way. Okay, so hopefully I won't mess it up. You can see here, that's a splenic artery right there, right? Splenic vein right here, SMV right there, pancreas right there, portal vein right here, and what is this? Aorta. One person aorta, other? Inferior vena cava. CBD. One of those is correct, by the way. It's a CBD. Okay. So that's what I was saying. See, every time you will learn, yeah. I'm looking from the stomach right now. So portal vein is here, CBD is there. These structures, imagine you're looking from the top down, okay? When you go into the duodenal bulb, your scope is in a longer position and you're looking upwards. That's why they flip. Bile duct comes closer to the transducer and portal vein moves away, okay? So this is the right diameter of the CBD because you're not compressing on it. So if you have to really check the diameter of the CBD, this is the place. And this is the place where you see the common hepatic and going into the liver. You can follow all that into the liver as well. So right there. Okay. Anyway, so next is going into the duodenal bulb. You can see that I've moved the scope to the duodenal apex. Scope is again kind of in a neutral position. Big wheel towards you. You will find one of those three structures, bile duct or pancreatic duct, portal vein or the pancreas. Once you find one of those, then you can follow the rest. So here the bile duct to go towards the liver hilum, rotating it to the left. And after I see the whole bile duct, then I'll come back to the ampulla. And from there, now I follow the pancreatic duct. That's an ampulla right there. And you can see the portal vein there. And then you can follow really the pancreatic duct all the way into the neck of the pancreas from there. So here you see those aorta came to the right, bile duct and the pancreatic duct. And from there, I don't know if I have to the left or not, but if you go to the, okay, actually this is what I'm doing, what I call a pull through. You see the whole pancreas in one movement from all the way from the ampulla to the tail. Did you see that? The pancreas stays underneath the transducer the whole time. So the way you do is, for the uncinate process of the, for the genu or the neck of the pancreas, always take a look from three stations. Take a look from the stomach, take a look from the duodenal bulb, take a look from D2. That's the area a little bit critical sometimes. You may miss one portion of it from one. So from when you are in D2, other thing before I forget, don't ever lock the wheels on the scope. Almost never, certain conditions, exceptions, certain exceptions. But when you're moving your scope, the wheels should not be locked, especially in D2. Let the transducer, let the scope free, because if the wheel is locked, and if you somehow fell back, you lose the control of the scope, you may run into trouble. Okay. It can just rip off the duodenum. So when you're doing what I call a pull through, you're at the ampulla D2, you just fall, you can't follow the bile duct. You can only follow the pancreatic duct through its entirety from there. So you just let all wheels neutral. Keep the goal is to keep the pancreatic duct right into the underneath the transducer. Follow that from the ampulla, and you should be able to trace the whole pancreas from the duodenal D2 all the way back into the stomach, just with one movement in 15 seconds. Okay, or maybe even less than that. So that's So you take a look at the pancreas from different angles. You can take a look at the whole pancreas from the stomach, then portion from the duodenal bulb, portion from the D2. So I think I'll stop there and this, and the next part is going to be the vascular relationship and tissue acquisition. Okay, I think Mustafa is available, so we'll go with him. Okay.
खालिद भाई आपने जो स्टमक से देख रहे हैं वो आप एंट्रेंस से देख रहे हैं सीबीडी को या फिर आप उसको जी जंक्शन पे ही है
It's in the middle of stomach. It's in the middle of the stomach almost. It's just wherever it gives me a view. That's it. Okay. इसको मैं निकाल दूँ। जी